research briefing on this topic because I think it's very important that some of the researchers coming through showed that PrEP was not just being of benefit to people in terms of protecting them from HIV, though certainly it has a very powerful ability to do that. But many fears had been asked to start at the beginning of PrEP as to whether its overall effect on people's health would be positive. And one of the definitions, the definition of health as adopted by the WHO, is not just to do with physical health. It concerns general quality of life, good mental health, and the ability to basically live one's life free of health problems. And fairly early on in the, you're advancing slides, fairly early on in the epidemic, it became, a number of articles came through in the gay media, basically discussing the way PrEP was affecting the lives of gay men. And this one jumped up particularly. I wanted initially to get the writer, Tim Murphy, to be one of the talkers here, but since then he's very annoyingly become a successful novelist and is a terribly busy man. But I liked the article, which was from 2014, about the time that it was licensed by the CDC, because it proposed the question, really, will PrEP take some of the fear of HIV out of gay men in this particular, in their particular discourse with life? I like the article because of the very respectful way it presented the participants as well. Next slide, please, Roger. I think there isn't just an epidemic of a viral illness with HIV, it's also been an epidemic of stigma, in the sense of it being a highly feared and stigmatized condition, which already re-stigmatizes populations that are disapproved of. And of course, that stigma then gets internalized and creates considerable anxiety, not just about HIV, but about the meaning of being HIV positive, about what kind of person you are if you catch HIV. And I still see this. I belong to a Facebook support group for people with HIV in the UK, and see the psychological process that people who are still catching HIV today go through. Next slide. Elske will say more about this later, but the idea of a syndemic has been talked about, which is the idea of a vicious circle, that gay men and other people at risk of HIV may suffer from anticipated and internalized stigma, feelings of low self-worth, feelings of depression, low self-efficacy, and that can lead them into harmful coping behaviors, poor agency over sexual risk. You either become hyper aware of your HIV risk, or you actually do get HIV. That may reinforce the situation. This also comes with pre-existing vulnerabilities to HIV, such as experiences of sexual abuse or intimate partner violence or things like that. I should say that this is not the only picture, but I think there was a lot of interest in PrEP's ability to possibly break this vicious circle by cutting through the link that represented anxiety of HIV. Next slide, please. One study and speaker that we didn't manage to get on was this very interesting one, which was a snapshot survey, so not longitudinal like the ones we'll be presenting, but which actually looked at a bunch of gay men who responded to an internet survey, and it found and said PrEP users had the best mental health of all the respondents. That means than HIV negative men who were not on PrEP and HIV positive people. Reduction in anxiety particularly remains significant. So there is plenty of scientific evidence that PrEP certainly reduces anxiety about catching HIV, but also may have more powerful impact than this, because one of the things they found was that gay men who had a lot of partners were quite anxious about it. But if they took PrEP, they weren't anxious about it, and therefore the it broke the link between perceived sexual risk and states of anxiety. Next slide. But I think it's very important to note that when people take PrEP, they are looking for something positive as well as trying to get away from something negative. We must never forget that even gay men are not just looking for the physical pleasure of sex, they're looking for intimacy and connection too. And that PrEP may enable gay men to break through or to achieve feelings of intimacy, according to some quite early and more recent research by one of the wonderful researchers in New York, of whom I'm a total fanboy, Sarit Golub, who actually found through asking gay men that if they were able to have sex, which the condoms had come to symbolize in many gay men's minds a barrier to intimacy, and that if they were able to have sex that didn't have that perceived barrier to intimacy in it, they felt a lot better and a lot more capable of achieving long-lasting relationships. Next slide. And skipping forward 8 years, I think the next generation of people that we need to inspire and motivate for PrEP is young women, particularly in the low-income world. And this is a very interesting article that Roger wrote that basically featured a motivational video that young women in Cape Town had taken a role in shaping. And what's really interesting, if you watch the video, I won't show it now, it'll take too long, is how the young women didn't particularly want messages about avoiding HIV into it. What they wanted was messages about taking control of their lives and their relationships. And very interestingly, they also wanted guys to be included as well, which wasn't at first anticipated. And so there are young men in this interview as well, talking about them taking control over their sex lives. And I think at the heart of the mental health improvements in PrEP that we've seen are a feeling of enhanced control. Okay, that's all I'm going to say. And now I'm going to hand over to Philip Keane, who is coordinator of the New South Wales HIV Prevention Partnership Project. Unless people have asked any specific questions in between times that need clarification. But it doesn't look like it. I'm also seeing a few apologies for having to leave early, which is fine, we understand, but no specific questions. So I will hand over straight to Philip. Okay. So Philip, if you can unmute yourself, or Roger can unmute you, and you can introduce your study and talk about your work. Oh, I see, that's my last slide. So Roger, if you'd get him up.
Sorry, it's my problem finding the slides, and that's, hang on.
In emergency, I can always put them up too.
Okay.
Welcome forward, lovely background.
We should be almost there. Hang on, sorry about this.
It's okay. As I say, in the meantime, if you do have questions, please feed them through to the chat. Here we go. Welcome, Philip. Are you unmuted?
You have to.
Yes, go for it.
Oh, I see you have now. Thank you very much. Well, look, thank you, Gus, and your colleagues at AmPrEP for the invitation to give this presentation today on behalf of Mohammed Hamoud, who is my co-first author on this study, and the other FLUX investigators. FLUX, which stands for Following Lives Undergoing Change, is an Australian open perspective observational study of licit and illicit drug use among gay and bisexual men. And between 2014 and 2018, approximately 4,000 participants joined the study. And in the data I'll be showing today, these were responses collected in 2018. Just one thing that's been happening recently in the study is that we've been collecting data on behaviour and PrEP in the context of COVID-19. So if there's time at the end in the discussion, we may want to discuss some of what we're seeing there. Next slide, please, Roger. So the data I'm presenting today were published in a paper in the journal JADES earlier this year. And what we think was significant about our paper was that, to our knowledge, it was the first data from a large quantitative study showing a relationship between PrEP and HIV-related anxiety among gay and bisexual men. And although, Gus, you said at the beginning that we were going to be looking at data from longitudinal studies, and Flux is a longitudinal study, the data I'm showing today is actually from a cross-sectional analysis. But because we do have longitudinal data, we will shortly be looking at that and analysing that for relationships in this area. Next slide, please, Roger. So in terms of background, we know that anxiety about HIV, as Gus said, and fear of sex with other men was very common in communities affected by AIDS in the beginning of the AIDS epidemic. And Walter Detz reported that even among HIV negative men who were in seroconcordant monogamous relationships where transmission was not even possible, some of those men were afraid of sex with their partners. And we know that still today, many gay and bisexual men report sex-related anxiety. Next slide, please, Roger. So with the advent of PrEP, we started to see data from studies where men reported that they wanted to use PrEP to decrease their anxiety about getting HIV. And we've now been seeing data from qualitative studies where men anticipated that using PrEP would reduce their anxiety about sex with HIV-positive partners. Next slide, please, Roger. And indeed, in studies of gay and bisexual men who actually use PrEP, people have reported feeling safer about sex, reduced anxiety about HIV, and increased sexual pleasure, which I guess, as you were saying, Gus, in your introduction, is one of the really interesting things about PrEP and the experiences we're seeing for them. Next slide, please, Roger. So the objective of this study was to assess whether PrEP use among non-HIV positive gay and bisexual men was associated with higher or lower HIV anxiety. Next slide, please, Roger. So this slide is essentially about the methods. So we focus in this analysis on 1,547 non-positive men who completed a Flux survey and answered questions about PrEP and sexual behaviour. And to measure HIV anxiety, we developed a new scale and asked the 3 items on the slide. So after having sex, I sometimes get concerned that I might have done something risky. Also, I sometimes worry about HIV before having sex. And when I'm having sex, HIV tends to come to mind. And we ran a multivariable logistic regression model to estimate adjusted odds ratios for factors associated with PrEP use. Thanks, Roger. So I just wanted to explain how we assessed men in Flux as being eligible for PrEP or not eligible. So on the screen here are what were at the time of the study in 2018, the eligibility criteria for MSM, heterosexual men, in the Australian PrEP guidelines. The guidelines were revised last year in 2019, and they're actually now much less restrictive. And I think, interestingly, one of the provisions, which I might look up after I speak, and so I can quote it verbatim later, but anxiety, I think people are being concerned about acquiring HIV, even in situations of relatively low risk, is now an indicator for prescription of PrEP in Australia, which I think is quite interesting. But what we did in terms of assessing men for eligibility was we used these criteria on the screen, and we matched those to data that were collected in Flux. The one difference was that in behavioural studies like Flux in Australia, we collect data that people report over the previous 6 months, whereas in data collected at clinics, where people were going to be assessed for PrEP. Those data are collected over the previous 3 or 12 months. Next slide, please, Roger. So this is the first of our results slide. And although I'm not showing the data on this slide, I guess I just want to give some idea of the sample. So of the 1,547 participants, 91% identified as gay, 7% as bisexual, and the other 2% identified as either queer, trans, straight, or no label. But of the participants in this sample, 37%, 575, were using PrEP, and the other 63% were not using PrEP. Next slide, please, Roger. So looking at eligibility for PrEP, 26% of the sample, which was 406 participants, were eligible for PrEP, and among those, 73% were using PrEP. But among the people who were ineligible for PrEP, which was most of the study, 25% of those people were using PrEP. And one thing that Gus asked in the lead up to today was, well, how were people who were not eligible for PrEP getting it? And something that we did hear anecdotally was that many gay and bisexual men in Australia learnt what they had to say to a doctor in order to be deemed eligible for PrEP, in order to get onto a trial or to get a prescription to privately import PrEP. So some people who were not at high risk, but who were concerned and wanted to go on to PrEP, got access to PrEP. And I think other people who knew that if they started taking PrEP, they could dispense with condoms, wanted to get access to PrEP because of that, even if they may have been largely safe, or even men who had some risk before that. Next slide, please, Roger. So these data show how HIV-related anxiety was different according to some of the factors across the whole sample. So they're not broken down by eligibility for PrEP or whether or not participants were using PrEP. But from the answers that participants gave on the 3 questions in the HIV anxiety scale, we calculated a mean score. The minimum score that anyone could have got on the scale was 3 if they had very low HIV anxiety, and the maximum score that people could have got was 18 if they had very high HIV anxiety. But these results show that younger participants had significantly higher HIV anxiety. And the next slides are just going to focus on the rest of this slide. So the next is Roger. Shows that men who were not in a relationship had significantly higher anxiety. And I think Sophie's message is obscuring part of the screen there down the bottom, but also men who reported any receptive condomless anal intercourse with a casual partner also had significantly higher anxiety, HIV-related anxiety. The next slide, please, Roger. These are the first results from our multivariable model. And the strength of a multivariable analysis is that it takes into account all of the factors involved and determines which ones are significant. So in this case, we see that among participants who were ineligible for PrEP but who were using PrEP, these participants had significantly greater social engagement with other gay men, and they also had significantly higher numbers of sexual partners than other ineligible participants. However, these results also show that after controlling for social engagement with other gay men and the number of sexual partners, HIV-related anxiety was not related to PrEP use among participants who were not eligible for PrEP. So among participants who engaged in less risky sex, PrEP use was not associated with lower anxiety. And we think this indicates that anxiety levels may have been related to how risky people believed that their behaviours were. Next slide, please, Roger. And these are the results of the multivariable model for PrEP-eligible men, and these were PrEP-eligible men who were using PrEP. And they show that among those who were using PrEP, they were more likely to be university educated. to have greater social engagement with gay men, and also to have more sexual partners, and to have lower HIV anxiety. Next, please, Roger. So the conclusions, I've actually raced through this, I've realised. HIV anxiety was lower among participants who engaged in what were previously defined as high-risk behaviours, although for participants who were on PrEP, these activities were no longer high risk. Whereas other participants engaging in the same practices who were not on PrEP had higher HIV anxiety. This suggests that firstly, among participants who engaged in so-called high-risk practices, they no longer viewed them as risky. And secondly, that participants who engage in those practices but don't use PrEP are probably aware of the risk and therefore more anxious. We think that by letting them know that their anxieties about risk-taking might be reduced if they take PrEP, that's probably a good way to create additional demand for PrEP. And the next slide, please, Roger. So this is the final slide. I guess I just wanted to thank all of the HIV positive and HIV negative people who participate in Flux. In this case, it was only non-HIV positive participants, but without participants in studies like these, studies like this would not be possible. And so I'd like to thank those participants and also thank the Flux investigators listed on the screen. Thank you.
Okay, many thanks. That's really clear and really interesting, Philip, and really actually gets into the heart of exactly what PrEP is doing. I wasn't aware that if I brought up the chat screen that it was blocking your screen, so apologies for that. I've now stuck it down by the side. Okay, I think we've had at least one really interesting question about fear of STIs, but I think I will leave that till the panel discussion because it's a more general one. Has anyone got any clarification questions that they want to ask now? A couple of minutes. If not, we'll move on to Elske's presentation. Okay, nope, all right. In that case, I will introduce the fabulous Elske Hoornenborg, who is head of the STI clinic of the Health Service of Amsterdam and is also the principal investigator of the AmPrEP study, which is the Dutch PrEP study among gay men. It is just gay men, isn't it, Elske? Yeah, one of the interesting things that AmPrEP did was that it's one of the first studies to offer, I think apart from Hypergay, was one of the first studies to offer in a demonstration, what is essentially a demonstration project, a choice between daily PrEP and event-driven PrEP. Anyway, what they also did was to conduct a very interesting study of mental health as measured in a number of different ways, longitudinally among the AmPrEP participants. So Elske will talk about that. So if you're unmuted, off you go, Elske.
Thank you, Gus, and PrEP in Europe for the invitation to share our findings here. And indeed, this is the paper and the publication I'd like to talk about: changes in mental health and drug use among men who have sex with men on daily and event-driven pre-exposure prophylaxis in Amsterdam. And this analysis of our AmPrEP data was mainly conducted by my lovely colleague Roel Achterberg, for whose picture you can see here. Next slide, please. This manuscript was published in eClinical Medicine a bit earlier this year, and this is a new journal from the Lancet group. Next slide, please. A bit about the background. So what we know is that MSM have poorer mental health outcomes and are more likely to use recreational drugs compared to the general population. And some of the changes, differences that we see can be explained by the minority model, which is the thing you can see here on the slides. And what you basically see here is that there are many factors and stressors that altogether lead to stress and mental health problems among men who have sex with men. And some of the factors can be general stressors, as you can see in the middle at the C. Some can be environmental stresses, but some can be, which you see at D, things that has to do with prejudice, discrimination, violence, and we unfortunately hear these events occur quite regularly among men who have sex with men. Next slide, please. So then what can happen is that you enter a vicious circle. And this is an example from one of the participants of our AmPrEP study. This was a very young, very handsome boy who had an extreme fear for HIV. And the fear was so strong that he didn't dare to have sex, not any sex at all. But he wanted to have sex, obviously. So what happened is he drank alcohol, excessive alcohol, because he felt that it diminished his fear. He had sex while he was drunk. And then what happened was incorrect or no condom use, or he didn't remember whether he used condoms or not. And after the sex, his fear for HIV had grown and was even worse. A very sad story, but the good thing is PrEP could stop this circle. And there's many other examples that you can make of these vicious circles, but for time's sake, I will go to the next slide, please. So we collected data in the Amsterdam PrEP project, and on the next slide, I will explain a bit about the Amsterdam PrEP project. Next slide, please. It is a PrEP demonstration project for 376 MSM and transgender people. And they all got the choice of daily or event-driven PrEP, and it was free of charge. The study is conducted at the Amsterdam Public Health Service. It's the building you can see in the uppermost picture. The study started in August 2015, and the phase 1 ended May 2018. Initially, we thought that we would have PrEP available in the Netherlands by then. It wasn't, so we expanded the study up to December 2020. Participants had 3 monthly visits. So what did we do for mental health assessment in this study? I'll show you on the next slide. We investigated the mental health of the participants through 4 different questionnaires investigating 4 different topics of mental health. And we did that at 4 time points. It was a baseline at 12 months, 24 months, and then at the end of phase 1. So that was about May 2018. So for some people, depending on the moment of inclusion into the study, that was close to the 24-month visits. And for others, it was almost a 36-month visit. Next slide, please. Our research questions were: 1, are there changes in mental health over time after initiating PrEP? And on the other hand, which factors are associated with change? Next, please. And we used validated mental health questionnaires, and that's always a good thing to use questionnaires that are validated, because the outcomes are more robust and you can compare them with outcomes from other studies. The first was a mental health inventory. It's a short 5-item questionnaire, and it investigates anxiety or depression. Second is sexual compulsivity scale, alcohol use disorder identification test, the audits, and the drug use disorder identification test, the DUDIT. And on the bottom of the slides, you can see the referrals to these validated questions. Next, please. So let's have a look at the type of questions that we asked. This is the MHI questionnaire. So it typically asks these kind of questions. You can read them It's very general about how you feel in the past 4 weeks. The total number of points you can get was about 100, and if you score less than 60, there's an indication for anxiety or depression mood disorder. Of course, it's not a diagnosis, it's just an indication. In the next slide, you can see the sexual compulsivity scale. That's a bit more questions. It's 10. Total score maximum is 40. If you score above 24, there's an indication for a sexual compulsivity problem. And you can see it's about struggle to control your thoughts. It's about doing things you actually don't want to do. And on the next slide, we can see the audit. It's maybe more known. It's about how much did you drink and did you do things that you don't want to do, or did you do not things that you had to do because of alcohol. Maximum score is about 40, and if you score 8 or higher, it's an indication of a problem. And on the next slide is the DUDIT, and that's similar to the audit questionnaire. Maximum score is 44, and if you score 8 or higher, it's an indication of a possible disorder. Then we ask a few other things. Concern about acquiring HIV. We asked it on a 7-point Likert scale. 1 is very concerned to 7 not concerned at all. And then we asked about sexual abuse or intimate partner violence, experiencing a drug-induced blackout, and whether they sought help for mental health problems. So now we're getting to the results. Next slide, please. Our participants that had data that we could analyze was, the number was 341. Most were MSM, only 2 were transgender. Median age was 40. Majority had a white ethnicity and had a university degree. So it's not a very regular group, as you can see. Follow-up was 2.5 years. At 12 months, we had still 334 in follow-up, and at month 24, it was 299. So that's a quite good follow-up. Next slide, please. So let's start about concern about acquiring HIV. You see per time point 2 columns. One is for event-driven use of PrEP, ED, and the other one is for baseline, for daily use of PrEP. And you can see that at baseline, you can see quite a lot of red, meaning that people were more concerned about acquiring HIV. And you can see from year 1 onwards a nice decrease in the number of people who are very concerned. Next slide, please. Now we're getting to the anxiety or depressive mood disorder. Again, here in red, you can see the daily PrEP users, and in black, you can see the event-driven PrEP users. And here you can see the proportion of participants who had a measure that gave them an indication for a disorder. You can see for anxiety or depressive mood disorder, this is about 20%. Well, quite significant, I'd say. And as you can see over time, there's not a real difference that we can see. But on the next slide, the sexual compulsivity, indeed, there you can see a difference. So it starts at about 20%, 23% when we measure it exactly. And you can see a decrease up to end of phase 1 to 10%. So that's a significant decrease. Harmful alcohol use, no changes over time. As you can see here, not in the daily and not in the event-driven group. And on the next, the drug use. And we can see a small decrease in the proportion that had drug-related problems. That decreased from 38 to 31%, and that was a significant decrease. Next, please. So Gus already mentioned the syndemic, the term syndemic, and the syndemic theory implies that two or more afflictions, diseases, problems, be it social, biological, or mental, can reinforce each other synergistically and thus can contribute to an excess burden of disease. So to put it simply, 1 + 1 is 3. Next slide. So do we see signs of a syndemic in AmPrEP? Well, we did. We did see that the development of one disorder frequently was associated with the development or lack of recovery of another disorder. And on the next slide, you can see the first example of those participants who had at baseline signs of an anxiety or depressive mood disorder. They were 30% less likely to recover from sexual compulsivity. And they were about 2.5 times more likely to develop drug use disorder. So there is a combination between the mental health outcomes that we measured. And on the next slide, there are 2 other outcomes. So it's for the people with a drug use disorder. They were 2.2 times more likely to develop sexual compulsivity and 2.5 times more likely to develop alcohol use disorder. And for those with a baseline sexual compulsivity, if you can go back for a second, they were about 50% less likely to recover from anxiety or depressive mood disorder. Next slide, please. So that's about the outcomes for syndemics. It's a complicated statistical model. If you want to know more, I can explain you. But the other outcomes are interesting as well. More than a quarter reported ever having experienced a drug-induced blackout, and 1/3 of those had experienced that in the past year. 6% reported intimate partner violence within the past 5 years. And 1 out of 7 reported ever having had a non-consensual sexual experience. 1/3 of those occurred before the age of 18. So here you can see some of the stones of this minority stress model. You can imagine if you experience those kind of things, that are factors that relate to your mental health. Next slide, please. What is our response as a public health service of Amsterdam? Well, all professionals that work at our sexual health clinic are well informed about chemsex and addiction, and they're trained in motivational interviewing. All our communication is non-judgmental, and that's very important and empowering. We offer peer support regarding chemsex. It's weekly on an evening at the clinic. It's peers, not professionals, and that's really well regarded. And monthly, we have a free of charge consultation with the mental health professional, a nurse working in psychiatric care, and that's like a pre-intake, getting to know each other and see if she would be able to help you. Next slide. We also try to contribute with our research to new interventions that are effective. So we did our SYNBAS-IN study, which was published, I think, earlier this year. And for this study, it's a slightly different study population. We included MSM at high risk for STI, both HIV negative and HIV positive. And we saw them 3 monthly for testing and counseling. And then we put in an intervention, an additional intervention. We gave feedback on mental health questionnaires that were completed. The primary outcome was self-reported and confirmed help-seeking behavior. So we tried to get people into mental health care. Self-reported help-seeking was 41% in the intervention arm versus 29% in the non-intervention arm. So that's a non-significant difference. And the same was for confirmed help-seeking behavior. So our intervention did not add to more help-seeking behavior, but I must say that more than 1/3 who did seek help for mental health. That's not bad, I think. Next slide, please. And then one other study that we did within AmPrEP, qualitative research performed by my colleague Hanne Zimmerman. Very short, we looked at sexual well-being and we heard many positive outcomes. PrEP relieves fear of HIV, increases self-esteem, etc., etc. You can see them in the column in the middle. However, what we sometimes forget is PrEP does have negative consequences as well. About half of those we interviewed had at least one negative thing that they want to mention. For example, preoccupation with sex, leading to distress or restlessness, or emotional problems related to problematic drug use. So I think we shouldn't forget those aspects of PrEP too. Next slide. I'm coming to my conclusions, and I concluded that mental health problems were highly prevalent in this cohort of PrEP users. We observed that the presence of one disorder was frequently associated with other disorders, the so-called syndemics. The proportion of participants with sexual compulsivity and drug use disorder decreased over time. I don't know why. Was it due to PrEP? Was it because people are less concerned about HIV or improvement of sexual health? That is a possibility. Or is it due to other program-related interventions, frequent counseling, referral if needed to professional services? And then the other thing is that possible negative impact of PrEP on sexual health needs to be further assessed. Next slide, please. My recommendations, and I hope we have time to discuss about those. Assess mental health in all PrEP-related research or programming, include mental health in counseling, and establish a good referral network. Let's design interventions to improve mental health in this group. And then my last slides is my acknowledgements. Zonmw is our funder, and if you click once more, Roger, thank you. We were awarded with a pearl for the AmPrEP project by Zonmw, this funder, because of the impact of this research project on policymaking and, well, getting PrEP to the people. Thank you.
Okay. So that's great. I think that's a great presentation because we're getting further into the sort of complexities of mental health in particular. And I really liked the way that your study particularly showed that if you, that pre-existing mental health problems can be a complicating factor, and that PrEP isn't an actual sort of magic bullet to solve people's lives, but it may help reduce certain aspects of distress. And I think that what's very interesting about these two studies and the other studies we quote in our research briefing, which I urge you to read, is that they all zoom in on slightly different aspects of mental health. And it's really interesting to see sort of at what point PrEP makes a difference and at what point it doesn't make a difference. I'm going to ask a couple of questions now because we're actually bang on time. Well done to the two presenters so far. It's fantastic. More specific questions. People have asked some really interesting general questions, which we'll save for the panel discussion. Firstly, Elske, what is the current state of PrEP availability in the Netherlands? I really sat up and took notice when you said it's not as ready as we were expecting it to be.
The good thing is it's available now for 6,500 people for a period of 5 years. So it's a capped national program, pilot program, similar to this situation in the UK up to recently. Mm-hmm. And well, we know that this 6,500 is not enough. We're now a year ahead in the program and we're rapidly reaching the maximum number, but
okay.
It's available.
Yeah. Rapidly reaching the maximum number, what will happen then? That's the interesting question we came across with impact as well. Okay, I've got one interesting question from Makinda Chahal. How did people, when given the choice, decide which PrEP routine to take, and did that choice, how did it compare with the outcomes of the mental health questionnaires? For instance, were some people who didn't really need to take PrEP based on risk daily, but instead it was being driven essentially by anxiety? Do you have any insight into whether there were differences in motivation between people who chose daily and event driven?
What we did, we discussed both regimens with all participants. And then we basically said, both have advantages, disadvantages. What do you want? And then obviously there was discussion. So sometimes it came to anxiety, and we explained that both regimens are equally effective. But there's more research outcomes known for daily PrEP. So some people did choose daily PrEP because they want more certainty to the PrEP regimen to be effective. But I think that's only a small amount. Most people estimated their risk behavior correctly, and we do see that those choosing daily PrEP have more partners, more often sex, than those who chose and get more STIs compared to those who chose event-driven PrEP.
Okay, all right, thank you. Right, I think I will introduce Will Nutland. I would say he needs no introduction, but actually we've got 54 people from all over the world at the moment, so he may need an introduction. And Will is a very experienced HIV prevention expert, and I know somebody who's very interested in sort of theories of change and the dissemination of ideas. He used to work at Terence Higgins Trust, and then he set up the very wonderful UK-based but not UK specific PrEP advocacy organisation, PrEPster. You'll see one of their cover slides up there right now. And he's going to sort of do a review of the general issues involved in these discussions. Okay, so Will.
Thank you, Gus and Matthew and Roger and all the folks at AmPrEP and all the folks at PrEP in Europe for organising today's seminar. It's great to see faces popping up for PrEP friends and advocates from all across the world. It's lovely to see you all here. In addition to being one of the co-founders of PrEPster, I'm also an honorary assistant professor at the London School of Hygiene and Tropical Medicine. I'm also a PrEP user. I'm one of the participants on the IMPACT trial and also sit on the Community Advisory Board for IMPACT. I want to highlight one non-PrEP related issue. I'm currently dealing with long COVID. One of my side effects is slightly cognitive. So I sometimes forget names. If you see me in the street, sometimes I forget your name, and I often forget words. My most recent one being I referred to the refrigerator as the cold oven the other day. That does mean that this is the first public presentation I've done since those symptoms have come in. So my apologies if I lose my words. I get a little bit confused from time to time. So I'm going to take us in a slightly different direction from the fantastic overview that we've just had from Elske and from Philip. First slide, please, Roger. For those of us who've been doing PrEP advocacy globally for the last 10 or more years, I think we've had kind of three key branches of arguments that we've been able to use around why we should be funding PrEP in our health systems. The first one, and often the most compelling one when we're having those discussions with government, is we now know that PrEP is cost effective and in many situations cost savings to our health services. The second is that there's a public health benefit. We can protect all of our public health by rolling PrEP out to people who are most likely to be to acquire HIV. Thirdly, there's the human rights benefit. But now I think we have two additional benefits to add to this. Next slide, please, Roger. The first is that offering PrEP is enabling some groups of people to access other sexual health services. And I know in England right now, we've really been able to learn from the fantastic work that's happened from the rollout of PrEP in Scotland. We now know that about a third of those people who have accessed PrEP in Scotland in the last 2 years, in the last 24 months, haven't accessed a sexual health service either at all or in the last 2 years. So PrEP has become this most amazing health promotion tool that is driving people into other sexual health services. So vaccinations, screening for Hep C, vaccinations for Hep A and B and HPV, access into chemsex services or other mental health services. This is an amazing tool that we can use to pull and drive people into our other sexual health services. But now, I think we have this fifth branch with a huge amount of very compelling evidence and data that helps us understand that in addition to the HIV prevention role that PrEP can play, PrEP can also reduce fear, it can reduce anxiety, it can give us better sex. So this kind of holistic model, holistic sexual health model around PrEP. And so I invite us in our international advocacy, our global advocacy around PrEP, to think about these 5 branches and how we might appropriately use them. And I'm going to come back to this in just a second, but Roger, the next slide, please. I wanted to just highlight that, this isn't new. Mitzi Gaffos in 2017 looked back at the great work that had been done on the PROUD trial that closed around 2014, 550 MSM and trans women in England. And Mitzi reported about the psychological impact of PrEP on those PrEP users. Next slide, Roger. And in Mitzi's presentation in 2017, she said, this data confirms what we've been hearing directly from PrEP users. PrEP has a bigger benefit than just preventing HIV. PrEP facilitates better sex, and it's reducing fear, anxiety, and stress. Next slide, please, Roger. So this is all continually backed up by ongoing community-based research coming out of the UK. PrEPster, I Want PrEP Now, in conjunction with Public Health England, has run 3 concurrent annual surveys for both people who have used PrEP in the 24 months before completing the survey, and in the last 2 years, people who've attempted to use PrEP but haven't been able to. Is just a very quick data slide. I think it's probably the only data slide I'm going to use that compares satisfaction with sex life from those people who were able to access PrEP in the previous 24 months and compared with people who were unable to access PrEP. So 70% of those who had accessed PrEP said that they either agreed strongly or agreed that they were satisfied with their sex lives, compared with 45% of those people who had attempted to but been unable to access PrEP. Next slide, please, Roger. And the 2019 PrEP user survey again reinforces this narrative that we've heard both from Elske and Philip earlier this morning. What's the impact? What's been your experience of using PrEP? Well, it's given me greater freedom during sex. It's reduced anxiety, greater feeling of intimacy with my partners. And I don't need to read the quotes out. They're there on the screen for you. Next slide, please, Roger. I don't know if Sean Harrington is joining us today. Sean has just had this piece of research published in HIV nursing. It's a great piece of research. Sean and his colleagues from City University. It's based on Sean's master's research, but really again reinforcing all of the stuff that we've heard today. Next slide, please, Roger. When Ian, one of the participants, says all these things would be going through your head while you're having sex, and it would be pretty distracting, as you can imagine. When you're having sex with someone, you really want to be enjoying the moment, and I never really could do that, whereas now I don't have that at all. So there is that, like, a level of intimacy and pleasure that I can be a lot more involved in. It's definitely made it a lot more liberating. And I want to make a plea to all of us here, all of us who are doing PrEP advocacy into the future, that everything that we're hearing about the additional benefits of PrEP, in addition to HIV prevention, it's very easy for us to focus on things like mental health, that we're having less anxiety and there's less stress. But what I really want us to do is, let's not sanitize some of the other great aspects of sex, of PrEP. That is, that what PrEP is facilitating for some of us is the ability to have kinky, dirty, mucky, slutty, cum-filled sex that some of us have really missed out on for the last couple of decades. And I know as a PrEP user, I'm gonna own it for myself. In addition to PrEP having an impact, a positive impact on my mental health, giving me less anxiety and less stress, PrEP is really allowing me to do stuff that I didn't think I would do as I hurtled towards my beginning of my 50s. And so one of the quotes that that Sean found in his research was that he said, "It changed my behavior by turning me into a bit of a cum whore. I developed a new fantasy of being given multiple loads by different guys over a day and or a weekend." And as advocates, I think we should be celebrating this. Thank you for my slide here called Cum Joy. And then in my own doctoral thesis, when I did the fieldwork for this in 2012 and finished it in 2016, this guy said to me, if I was on holiday in place X and had been taking PrEP, I'd think, fuck it, and go to name of bar of a night and come to find me in the morning with a mop. You know, so a mop to clean up all of the cum that's all under him from the sling that he's been in. And I should just say that the names there, Harrington and Nutland, are referring to the researchers and not attributed to the quotes of the people there. So next slide, please, Roger. What might this all mean for us in practice? How can we, as educators and activists, really start to sell the joys of PrEP to people we work with? PrEPster has been running something for the last 4 or 5 years called My PrEP Story that really pushes the voices of PrEP users to the fore, making space, supporting and enabling those voices. And we've really pushed to include the voices of people who are talking about those additional benefits of using PrEP. So Lewis, he says, I've been taking it for a couple of months and you know what? Sex is great for me. Have my anxiety significantly reduced? Yes. Next slide, please, Roger. And then our siblings project over in Amsterdam, PrEP New, they've been doing something very, very similar. Before being on PrEP, I was always scared after condomless sex. Go and have a look at some of the great narratives that they've done. Next slide, please, Roger. But one of the things that we've also been pushing through PrEPster is not just focusing on the narratives of men who have sex with men. For those of you who were in or who saw Nicholas Faustel's PrEP 17 film that he did with us in 2017, Winnie Saruma makes a really important point that PrEP gives women control. It puts them back in control, particularly if their sexual partners aren't wanting to use condoms. Roger, can you skip the next slide? Go on to the next slide, but then go on to the next one. Thanks. So here, no, go back one, please. Great. Here we have Akia, who was in one of the videos that we made 2 years ago. And what we decided to do with this particular video is that we were getting tired of hearing narratives about PrEP and women, about PrEP being for women, about risk and about vulnerability. And instead we wanted to turn that round and hear narratives about PrEP being around sex and pleasure and being in control of your own sexual life. And at the very, very end of this video, Akia looks at the camera and kind of winks and says, yeah, for PrEP for me, I'm having the best sex ever. She's very, very unapologetic that PrEP isn't just about autonomy and lack of anxiety. It's about sex and sexual pleasure. Next slide, please, Roger. And then PrEPster's project for women that was called MobPresh, and an output of that project that we're doing with I Want PrEP now is about to come out. Very empowering voices of women talking about, whilst PrEP does give them control, it is absolutely about pleasure, about having the sex that they want to have, and having the sex that they most want. So I think these are the directions we should be moving in, about repositioning sex on PrEP as about pleasure, as well as reducing stress and anxiety. Final slide for me. I know that there are some people in the audience who are also part of this, but a heads up at a great anthology of writing about PrEP and U equals U is coming out from Australian colleague Sue Kippax and her teams. Have been working on this, and pretty much everything that I've just talked about, the examples I've talked about, will be in a chapter called New Potentials for Old Pleasures, the Role of PrEP in Facilitating Sexual Wellbeing Amongst Gay and Bisexual Men, written with Brian Kuttner and Adam Bourne, that coming out later in this year. No, final slide, please, Adam. Sorry, Adam. There you go, I've done it. There's the COVID going in. Roger, thank you. Really, really happy to take questions with the other panelists. Thank you.
Okay, great. Thank you very much. I've got some really, really good responses, really interesting questions. We are more or less 3 minutes behind the schedule, which is fantastic. Far better than a lot of webinars I've been on. So we've got half an hour to ask some questions, and I've got some really rich ones anyway that people can either ask themselves, or if you want, I can ask on your behalf. I would I should, with Will, the other thing I forgot to say is he's actually on the steering committee of PrEP in Europe, which, you know, we're a kind of loosely constituted organisation with a secretariat at AmPrEP, but we have a bunch of sort of elders who advise us on what to do, and he's one of them. Okay. Please also note, I'm not going to answer this as a question. There's a great update on the situation in Greece in the chat panel from Yanis Mameletsis. He's addressed it to everybody. That's more, I think, for information than anything else. Thank you very much, Yanis. And that's a reminder of each country has to make its own case for PrEP. I don't quite know where to start because there's so many good questions. I'll ask a specific one and more or less in order. This is one that came up from Tom Craig for Philip, but saying that generally he says, basically on the PrEP Facts page in Facebook, which a lot of you will be aware of, terrific resource, he's seeing a lot of people, a lot of guys who seem to be sort of substituting fear of STIs for fear of HIV. In other words, you know, that if you have an anxiety about sex and sexual health, maybe it's unfortunately transferable. And that people are sort of worrying about things like catching drug-resistant gonorrhea or drug-resistant STIs because people don't know the difference. Are people sort of coming across this with some of your patients?
Well, thanks very much for the question. And Mohammed and I saw that in the chat, and amazingly, Mohammed has literally just run an analysis while we've been going today, and he's sent me the results in text message. So in Flux, in the Flux study in 2019, among all non-HIV positive men, only 3 out of 682, so less than half of 1%, of men who were on PrEP said that they stopped using PrEP because it didn't protect against other STIs. Mm-hmm. And among men who were not using PrEP, 6.6% said that they didn't use PrEP because it didn't protect against STIs.
Mm-hmm. Okay, all right. I have a feeling, this is purely observational and has no data to back it up, that social media support groups tend to attract the people who will tend to have the most anxious questions. So we may be seeing that as much as anything. But you know, I think concern about STIs mustn't be completely dismissed, certainly. I have a really interesting question from Garrett, which feeds into one of the things that Will was saying about, like, we mustn't, you know, a lot of this is about pleasure, not about kind of the dissolution of anxiety. Garrett, if you're there, do you want to ask your own question? Because I think you're probably better asking it than me. If you're not, I can do it for you.
Can you hear me?
Yes.
Okay, all right. I need to go back and look at my own question.
I can ask it for you if you like, and you can
No,
comment.
it was in response to the issue about measuring sexual compulsivity, and what I was basically trying to raise was that the measure. I think it's a very pathologizing measure myself, but the measure isn't necessarily measuring what you might think it is in this case, because presumably before PrEP, they wanted to engage in various behaviours, particularly condom or sex, and then when they start PrEP, that means that they're now no longer having to, constrain those desires. So it isn't necessarily there's a reduction in compulsivity as much as freeing up of desire and removing the barriers that they felt that were there to their own expression of sexuality. And particularly I'm thinking about that because in our flux data, prior to commencing PrEP, while the men who eventually then started PrEP, of course they were engaging in higher risk behaviours than those who didn't, but nonetheless, after they commenced PrEP, their sexual activity in general, and particularly condomless sex, increased enormously. And yet what didn't change was things like the measure of sexual sensation seeking. It remained static. So it wasn't a change in their psychology. It wasn't a change in their desire. It was a change in what they perceived they were able to do because of what PrEP had done. Does that make sense?
Yes, it makes sense. Sexual compulsivity is an interesting idea because I suppose you do have to be, I hope Elske's slide made it clear what the sort of questions they ask. But if you experience less sexual compulsivity, I guess the result in terms of behavior could be either that you have more sex or you have less sex. Because if lots of sex has been a coping behavior, you might have less or only have it with kind of the people you really want to have it with. But if on the other hand, the feeling of compulsivity is due to anxiety and people feeling restrained from what they really want to do, then yeah, you'd probably have more if you felt less compulsivity. So it's an interesting thing, and I think illustrative of the fact that it may not just be the amount of sex people have after PrEP, but also the kind of sex they have that needs continued investigation. What do you think, Elske?
I hadn't thought about it this way, and I think it's a very interesting point of view. Thanks a lot for that, Gareth. It has questions that really could have lower scores because of what you were saying. Some others, though, like my sexual thoughts and behaviors are causing problems in my life. Yeah, well, and my desire to have sex have disrupted my daily life. I'm not sure. I think it would be interesting to look more into which parts of this scale were particularly lower scores over time. But I think it's a very interesting question, and we must say it's a slightly older questionnaire. I think it was validated somewhere in the last century. So yeah, it could be that we need a new sexual compulsivity scale.
Mm-hmm. Okay. Eliane, are you there? You say you have a question for Elske, and you asked a question earlier on as well about young people and women in Netherlands particularly, but I think that we can talk about that generally. Have you noticed particular anxiety about discrimination or stigma associated with PrEP? And I think it's part of a general question about how we spread the message for PrEP amongst young people and young women in particular. Eliane.
Yes, because seems like most of the target group is the men who have sex with men, but everybody need to enjoy the sex, and everybody is afraid of getting HIV. It doesn't matter how you get it, which way. Yeah. If it's for men who have sex with men, it's not only Netherlands people, gay men only who have HIV, but I think the reason why also there is a stigma around using PrEP, it is also the way they make like a campaign for it. We need to, I think, is it not really, though they don't talk, you don't hear women aware of about the PrEP. When they are, for example, you look on Instagram, you will see PrEP and New Pentenaire, they will show parties with only gay people. And then when I'm talking from migrant background, and when this target group, migrant, for example, they will see that kind of information, they are very, they don't even dare to ask more because they think it's only helping gay men. So we need to look the way we communicate and the way to inform the public about this, because the PrEP is for everybody. I know the big percentage of people who get infection is more gay people, but I think we have to look also other percentage, even if it's 1% of, we don't have to leave anyone behind. So we're bringing in a public PrEP as a knowledge, then we should look how also to inform everybody and make sure the campaign target everybody, not only one big group. So my question to Ers, how are we doing with the PrEP for women in Netherlands?
Thank you, and I agree, we should leave no one behind. If we look at who gets infected in the Netherlands, it's mainly gay men. From all new infections, 2/3 are gay men. And the 1/3 of new diagnoses among non-MSM is a very heterogeneous group involving transgender persons, Dutch heterosexuals, people with different migrant backgrounds. And that makes it really hard to pinpoint groups that can benefit from PrEP, because it's such a heterogeneous group. And that's the reason why we have not yet really targeted women in the Netherlands yet for PrEP.
But we have like 14% of people in Netherlands who don't know that they have HIV, isn't it?
It's a bit lower, but yes, we
Lower?
do.
Yeah, but when it comes to, how about then for the new generation, like young people, how do you see it in the Netherlands to make sure information of PrEP is also available for schools? They know, like those high school teenagers, they know that the PrEP is also good to protect for the HIV. Or, of course, the condom is still the best for them if they like, but it's very important everybody know that I have a choice. I can go for PrEP or I can go for condom.
Well, in our Dutch guideline, we now don't mention young heterosexual women yet as a target group. And Gus, I don't know if we have time, but it would be interesting to hear from other countries and from the UK whether they're targeting women for PrEP.
I know in the UK they have like a PrEPster for, I used to follow them. I saw women, some information where the women are talking about how they use the PrEP. So that's why I was saying like in Netherlands we are far away behind, so we have to hurry up.
I'll ask Philip and Will whether they have comments on that, really. But it's kind of a subject that I wanted to introduce in my initial introduction when I ended up with that slide about the video that was made by the young women and for the young women in Cape Town. I think we're at a very complex stage in sort of messaging on PrEP, because we do need to expand the message about PrEP beyond the gay community and to some extent the progress we've made with some people of the trans community, and young women in particular in parts of the world where they are vulnerable to HIV are a particular population that need to know about it. But the messages that the way we, for lack of a better word, sell PrEP, not literally, but the way we message PrEP to different populations will have to be different. And if it becomes associated only with gay men, then that may also become part of a negative perception of PrEP. So we need to be kind of careful and subtle and tailor our PrEP messages to different countries. I wondered if Philip and Will had something to say about these issues.
Philip, do you want to?
We'd like to go.
Okay.
Well, I'll just say something briefly. I guess we're in the lucky position in Australia now that PrEP is subsidised on our pharmaceutical benefits scheme, and the PrEP guidelines, as I mentioned, were revised in 2019 and are much less restrictive. So one of my colleagues at the Kirby Institute, Nick Medland, has been doing an analysis of PrEP prescribing under the pharmaceutical benefits scheme, and there has been PrEP use among women. One thing that he's noticed is that often PrEP use among women, it's not extending over a long period of time. So we think it may be people, women using it at times of pregnancy or wanting to get pregnant if they have an HIV positive partner. But certainly there's nothing in the guidelines to exclude a woman who was seeing herself as having sex that put her at risk of HIV from being prevented from receiving a prescription for PrEP. I think a lot of the way that PrEP has been promoted, however, in Australia has been to gay men. So awareness of PrEP among heterosexual women, I imagine, would be very low. So I think that is a barrier. But I think what we will be seeing more of in Australia is promotion of PrEP to at-risk heterosexuals, including women.
Eliane, I excuse me. I think that it's appalling that we have such a lack globally of women who are using PrEP. We have 25,500 people in England on the impact trial, and fewer than 1,000 of those places have been taken up by people who aren't gay or bisexual men. So whilst you might have an observation that we're doing quite well in the UK, I don't think we're doing as well as we could be. PrEPster was involved in a project 2 years ago with 3 outreach teams in London called the GMI Partnership. And they did outreach to about 1,200 people across the year, and each of those people were asked to do a PrEP self-assessment questionnaire at the end of that outreach intervention. When you ask gay or bisexual men, what's your biggest barrier to accessing PrEP? The answer is cost. When you ask women, what's your biggest barrier to PrEP? The answer is knowledge. I don't know about it. So we've still got huge amounts that we need to do to increase knowledge amongst women who could benefit from PrEP. I want to again make a plea to all of us who are doing advocacy and education around PrEP, that when we talk about messaging, we do so in 2 ways. One, it's very clear that when we need to talk about from the ModPresh project that PrEPster ran last year, when we talk about PrEP, it needs to be embedded in broader sexual and reproductive health conversations with women, and not just go in and start talking about PrEP, especially if it's a new technology that most of those people don't know about. But my second plea is when we talk about messaging, is we're not just talking about social media, social marketing, and broadcasts health promotion messages. One of the best ways of helping people to understand about PrEP is through face-to-face conversations or online conversations that aren't about spending tens and thousands of dollars and euros on back of buses and billboards that's really, really badly targeted. The vast majority of people who are going to see that will never need PrEP. I want us to call for proper investment in outreach and face-to-face interventions that really dig deep into those communities who need to know about PrEP now, and that's going to be much more costly method than we've used for all of the kind of the broadcast and social media and Instagram stuff that we've done with MSM. It has a role to play, but it can't be the only thing that we do, and in lots of parts of Europe that is the only thing that's being done.
Okay, thanks. Of course, needless to say, we've got 9 minutes left and the questions are queuing up specifically about particular groups. Yanis Mameletsis, currently in Athens, you had a really interesting question about migrants, of course, and this is a subject that's particularly important in Greece, but do you want to ask your question?
Yes, hello everybody. Reporting from Athens. Nice to see friendly faces, and thank you to the presenters. Obviously, many of you probably have followed the news, and you've known that one of the largest refugee camps in Greece, Moria, burned down in the island of Lesbos earlier in September. It's a very relevant topic, sort of more broadly to public health, but as far as HIV prevention treatment services in this country, and kind of to Will's point on the messaging more broadly around SRH, we really are missing this population in Greece. There's investment, of course, that goes into many of the camps from organizations like UNHCR. There is European Union funding, but when it comes to SRH services specifically, I think we are missing the ball. And so, importantly, and I think I mentioned this sort of earlier, we have yet to implement PrEP formally in Greece in any shape or form. However, there is a pilot that we are looking at implementing in Lesbos in offering better services to migrant refugee women. And within that, we actually want to raise awareness around PrEP as well. So it's not just focusing on the MSM community here in this country. So all that said, I'd like to ask those that presented and maybe others on the call, what is sort of your current efforts in your countries around reaching specifically migrants, refugees with PrEP and other SRH services? Thank you.
Elske, would you like to go first?
Yes, that's fine. So what we do is we do go to these to places where asylum seekers temporarily live to explain them about our services, which are free for all, so they can access those. We do that a couple of times each year, and we try to liaise with the doctors who work there to make sure that they refer people to us. And in addition, we're really looking into ways to get into contact with newly arrived migrants who got a status, who can stay in the Netherlands, to make sure that what we offer is well known to those. It's not easy, but this is what we try to do.
Perhaps I'll just mention, I mean, thank you, Yanis, for the question, because it's a very topical point in Australia at the moment. What we have seen in recent years in Australia is really quite a remarkable decline in new HIV diagnoses among Australian-born men, mainly among MSM. Infections among heterosexuals have not really risen or fallen much in Australia, but we have seen a remarkable decline in infections among Australian-born men, but no decline in infections among overseas-born gay and bisexual men, mainly Asian-born gay and bisexual men. And both Garrett and Mohammed and myself are involved in the development of a new HIV strategy in New South Wales, which will come in from next year. And that group will be a key priority group for new action under that strategy. Some of the things that we're looking at are trying to connect migrants, many of whom in Australia are temporary migrants on student visas and temporary work permits, but to try to connect them with sexual health services earlier. What we see is that when people do get connected with public sexual health clinics here, they have the same rate of testing and PrEP uptake as Australian-born men. So the challenge is to connect them to services. So some of the ways that we're going to try to do that are still being worked out, but we're going to be doing things like working through universities and English colleges and things like that, but it's very topical now.
Okay. I think I'm going to move on, if Will doesn't mind. Yeah. To the last two questions, because we've got a couple of questions that have been hanging on for a while. The first one is about, I should say, I won't ask Roger to put it up, but the last slide I had after Will's presentation, actually I can ask you to put it up right at the end, was that our next planned webinar, we are hoping, well, we're planning, will be about trans people, about trans women, men and non-binary people, and PrEP as the entire subject. But Michelle Ross from Clinic Q in London would just like to say a few things about what's happening with their work with trans people. So Michelle, if you just want to say a few words about it.
Sure, yes, thanks, Gus.
Yeah, hello.
Just to say that I'm really looking forward to that panel, the next webinar, clearly. And I'm Michelle Ross of Clinic Q, and you know, we do a lot of work focused on trans people and PrEP, and have done right from the start, and before that, before the PrEP trial in England, and we'll continue to do so. And we have a panel later in October, and I said this month, I meant later in October, which the very lovely Gus has agreed to be on as well. But we'll have an international guest speakers.
Yes, and you need to email me about the details, Michelle. Anyway.
Yeah, I will. Sorry, I was just waiting for someone to get back to me with a final date. But absolutely, an international guest speakers, and it's all going to be about sex, PrEP, and HIV and trans people. Fantastic. Okay, I think, is that what I'd say? I think that's about it. And by the way, you know, PrEP really works for trans people, as Gus can confirm that. And, you know, when I hear, I've not heard very much said about PrEP and trans people in this section. They've been mentioned. I know people in Amsterdam that are on PrEP, and I know people in Amsterdam that, you know, want PrEP availability. Anyway, I'll leave it there. I could go on.
And I can think of at least one of those people who is going to be presenting at our next webinar. So that would be great. Okay. And way back, Tom Craig asked, pricked up his ears and said, "Oh, Philip, you never mentioned the work that you had done or were doing on COVID." So I think it makes sense in the last minute if we ask you a very quick question about that, because it may be appropriate to sort of round off with the current health challenge facing us.
Sure. Well, just so very quickly, Garrett and Mohammed at the beginning of the shutdown here in March instituted a great new project in Flux, which was a new promotion of Flux with a new intake who had a baseline questionnaire and both monthly diaries, which ask a number of questions. Well, we ask people to fill out diaries both on a monthly basis and a weekly basis. So we're getting very rich data. What we saw is that about half of the participants who were on PrEP stopped PrEP. Some people are starting to have sex without restarting PrEP, so that's a concern. One thing that has not really been promoted in Australia is on-demand PrEP. So there's low awareness about on-demand PrEP, which would be suitable for people like that who are having occasional sex at this time. But we are quite concerned about when we come out of COVID, whether people are going to restart PrEP in a safe way.
Mm-hmm. Okay. Brilliant. We haven't got time to add some of the studies that have been done about, particularly about gay men reactions to COVID. There's been at least a couple in the UK. You can, I think, read them on AIDSmap. But I'm going to be very strict about time and say thank you very much for participating. Roger has just put up my last slide, which is the research, the links to the research briefing that says contains a lot more, both in the gay media and in the studies about this subject, and that's also notifying you about the next webinar. Thank you very much for participating. We had 50 people throughout and very little drop off, which is always a good sign. And we look forward to seeing you for one of our next webinars. As I say, we're definitely doing one on PrEP and the trans community, and I think the first one we'll be doing on the new year will definitely be about PrEP and women. So thank you very much and goodbye. Oh, and we'll make the recording available on PrEP in Europe and probably on AIDSmap as soon as we can process access it, okay, because it's obviously a big one and we'll probably have to put it on YouTube. Okay, thanks very much.
Thanks. Bye-bye.
Bye.
Thank you. Bye.